together, which I'm pretty sure I do. I maybe missed a couple things, but for the most part, I'm good to go as far as that goes. Okay, so I'm going to make sure, again, we're dressed correctly. I'm going to use right terminology and pronunciation. So my name is Jason. I'm the student nurse today. I'm going to be doing a head-to-toe assessment on you. I'm going to have to touch you several times throughout this assessment. Is that okay with you? Okay. So this will probably take about 30 minutes, all right? I'm going to start at your head and work my way down to your toes, okay? The first thing I look at is the appearance. The patient is well dressed and dressed correctly for the weather, okay? Behavior is normal for situation. Patient is tall, skinny, African-American male. And I watched him walk as he came in. He's already in the bed, but he has a good gait, mobility is good, and all that kind of stuff. All right, so now I'm going to look at, can you tell me where you're at?
Bethel University.
Okay, can you tell me what day of the week it is? Tuesday. It's Tuesday. All right, can you tell me who the President of the United States is?
Donald Trump.
Okay, and can you tell me, what you're here for today?
Just to do self-assessment.
Okay, so patient is awake, alert, and oriented times 4. He knows person, place, thing, time, and situation. All right. Patient communicates well, speech is clear and understandable. I'm going to ask you a question. Can you answer it for me? What does the term "a bird in the bush" or a bird in the hand is worth 2 in the bush mean? You don't know? Okay.
Yeah,
what's it mean when somebody says the grass is always greener on the other side?
Just perspective. Just trying to see like somebody else, what somebody else has over there.
Okay. And
Over here.
what would you do if you saw a house fire?
Mind my business.
Mind your business. Okay.
Yeah, we assessed that. I did that assessment.
All right. So
That's
he's,
cultural assessment.
yeah. No, that's that. Where are you from? That's why. That's a Memphis. That's a Memphis answer.
Memphis, I'm gonna call the police.
See,
For a fire?
Listen,
What are they gonna do?
Call them, call the
So deep,
ambulance,
you
outside
like to mind
people, all
his business, 'cause
that.
that's how you get shot.
Yeah, but again, it depends on where you're from.
No. I'm from Memphis too. If I see
Where
a
you
fire,
from?
I'm gonna call.
See,
I'm from Memphis,
What part?
East Memphis.
Yeah, no.
Yeah, say.
I don't know. Yeah, East ain't as bad as you get into. Yeah, West is a little rougher. South has gotten a little rougher too. All right. So anyway, he's answered the questions correctly at that point in time. Now that y'all got me off track, so now I'm gonna go through and do vital signs. Right? I'm gonna do pulse, all that kind of stuff. Do I need a demonstrator of that, or do y'all understand that? Okay. I mean, I can, but. All right, so next thing I'm going to do is I'm going to look at his head, and as I'm going, I'm just going to take a look at you for a few minutes here. If you want to sit up for a minute, let me put this pillow right on your head. Lay back with your head on that pillow for me. Are you comfortable? Would you like to be a little bit more comfortable? I can set you up a little bit while I'm looking at you, if you don't mind. So I'm going to come over here to the bed, and I'm going to adjust the head up. You just lay there. I got all this under control. I'm pretty good at what I do. Is that more comfortable for you? Yeah, you're gonna go to sleep on me, aren't you? All right, so the first thing I'm gonna do is I'm standing foot in bed. If you don't mind, just look straight at my nose, okay? I'm gonna take a look at the patient. What I'm looking for is symmetry of the head face. Head and face is symmetrical. Head is normal cephalic. And now, if you don't mind, I'm gonna touch your head real quick, okay? So I'm gonna put on some gloves. Now, on this patient, I probably wouldn't put on gloves to touch his head. I'm just going to be completely honest with you. And the reason why, he's fairly clean, that kind of stuff. And I still believe in human contact in nursing. So sometimes touching a patient on bare skin, as long as yours is not broken, is perfectly fine. Does that make sense? Now, if you're doing IVs and you're doing skills, you need to go ahead and put your gloves on at that point in time. But touching somebody's head, now, women are a little bit different because they put a lot of stuff in their hair. A lot of product and stuff like that. So I tend to wear gloves when I touch their head. But men, for the most part, don't put a lot of product in her hair and that kind of stuff. I don't even comb mine when I get up in the morning. I do this and it works out great for me, okay? So the first thing I'm gonna do is go through and I'm gonna feel his head, okay? Patient has slightly receding hairline, okay?
oh my God.
All right. Patient has no lumps, bumps, or bruises on his head, complains of no pain on palpitation, all right? And then I'm gonna go through and I'm gonna look at his neck, all right? So the next thing I'm gonna do is palpate the carotid arteries, and then I'm gonna listen for carotid brewery, okay? So what I'm gonna do is put my finger on the side of your throat. I'm gonna put it on the left side first and the right side second. I'm gonna add a little bit of pressure. I'm not gonna hurt you in any way, okay? If you could lay your head straight back for me, there you go. So I'm gonna come over here and feel for that carotid artery. Pulse present, +2, normal rate and rhythm. On the left side, pulse 2, normal rate and rhythm. Excuse me, on the right side. Pulse 2, normal rate and rhythm on the left side. I'm now going to take my stethoscope and take a listen to those real quick, okay? All right. Carotid arteries clear bilaterally, no bruits present. All right. Now, excuse me. Now that I've done that, excuse me. I'm walk back to the front of the bed. If you don't mean, keep your head back for me, especially with that bearded swallow for me. Trachea is midline, no JVD noted. Okay. Swallowing's going to let you see where that trachea is at. Does that make sense? All right. So once I've done that, I'm going to turn around and go to thyroid. So what I'm going to do is I'm going to actually reach on both sides of your neck. You're going to feel a little bit of pressure on one side. I'm going to feel it around with the other side, and then I'll swap sides, okay? Head back for me once again. I'm going to take my fingers and push the thyroid this direction. No nodules present on the left side. No nodule presence on the right side. No complaint of pain on palpation. Patient's thyroid isn't within normal limits, okay? Then I'm going to go in and do the lymph nodes, all right? So the first thing I'm going to do is you're going to feel me touch around your ears, and I'm going to move down your jawline and into your clavicle area, okay? So the first thing I'm going to do is come here and do preocular, correct? Postocular, correct? Submandibular, right?
Occipital.
Occipital, sorry, occipital, submandibular, right?
No.
Submental.
It's preocular, postocular, occipital, tonsillar.
That's right. Okay, tonsillar and then submandibular, and then I'm going to go down to the supraclavicular, right?
No.
And I'm going to feel all those. No tenderness noted, no pain noted. Again, I'm just going to feel them.
Yeah, okay, I got you. Yeah. I'm messing up.
If I'm going to feel them, I'm going to feel them, and if I feel something weird, I'm going to go find out which ones those are. Does that make sense? Okay, so once I've done that, I'm then going to go in and do my external eye. So what I'm going to do is have you hold your eyes open for me. I'm going to take my thumb and put it on your bottom lash and take a look at the conjunctive of your eye, okay? So I'm going to come in here and pull down. Conjunctive is pink. Eyes are brown. Eyes are symmetrical and normal shape and size, all right? Now I'm going to go ahead and move down to the next step, which is going to be the near vision. So what I'm going to do is I would have him hold the Rosenbaum chart, but what I'm going to do is instead of get him up, I'd get him up at this point in time, have him stand at the thing. So stand up for me. I want you to go stand on that brown square. Actually go behind Christian because, or just stand there, it's fine. You know, we know what we're doing. This chart over here, sir. So cover your left eye. And read the lowest line you can read.
I wear glasses now.
Okay, that's fine. Just read it for me. Is it F?
LPED.
All right. Cover the other eye and do the same thing.
LPD.
Go one more line up.
TOZ.
All right. So he's 20/50 in the right eye and 20/70 in the left eye, uncorrected. All right, because since he wears glasses, you're going to say that. Does that make sense to you? If they're wearing glasses, you're going to say it's corrected. All right, you can come back over here and have a seat for me now. Just sit on the side of the bed for me. All right. All right. So the first thing I'm going to do is take my pen light, and I'm just going to hold it right next to your eyes and see, look straight ahead at my nose. All right, so pupils are a 3. All right, now what I'm going to do is take the light, continue to look straight at my nose. I'm going to take it, and let me double check, make sure I'm in the right spot. Pupils are a 3. Yep. So now I'm going to do look at a pupillary response for light. So I'm going to flash the light in your eyes real quick. Just look straight at my nose. Ready? Pupils are equal and reactive to light. Perla is present. Now I'm going to ask you to take a look at my finger, and then I'm going to ask you to look at 2 different things. I want you to look at my finger, and then I want you to look at the kid in the bed over there. Okay? My finger, the child. My finger, the child, my finger, no, my finger, the child, my finger, the child. All right. So Perla is present with this patient. So now at this point in time, I'm gonna go ahead and take the ophthalmoscope and I'm gonna take it on each side and I'm gonna shine it in the eyes, and what I'm looking for is the red reflex. And I can actually do that with a flashlight. This one's just a little too bright, but what I'm looking for is that red dot in the eye like you see in pictures. All right, red reflex is present bilaterally. All right, and then once I do that, I'm gonna go in and do the sinuses. So right now I'm gonna feel on your face. I'm gonna start at the top and do the frontal sinuses, right? Is that giving you any pain or any pressure? Okay, how about this? All right, sinuses are clear, no pressure and no pain on palpitation, all right? So now that I've done that, I'm gonna move down to the nose, okay? So I'm gonna look for nasal symmetry. Nose is flat, symmetrical in the face. Take your hand and cover this nostril. Take a breath in, and then do the same thing on the other side. So cranial nerve number 1, the olfactory nerve cranial nerve 1 is functional. There we go. Sorry, brain fart. All right. Now that I've done that, I'm gonna go ahead and ask you to put your head back for me. I'm gonna take a look inside the nares. There's many hair. Mucosa is red or is pink as it should be. Patient has turbulence present, and yeah, that's it. Okay, so now that I've done that, I'm gonna go to the ear. I'm gonna inspect the pinna. I'm gonna do both ears at the same time. So I'm gonna come up here, do the pinna. Any pain? Okay, and nothing like that. Okay, once I've done that, I'm gonna ask you to sit right there. All right. I'm then gonna look inside the ear. I'm gonna pull back. All right. Ear canal is clear. Tympanic membrane is intact. It's what is it? Gray and glossy. And then I'm gonna go to the other side and do the exact same thing. All right. Ear canal is clear. Yeah, I can see it. All right. And then I'm gonna do the same thing as far as the disc is concerned. Then I'm gonna ask you to stay right there. I want you to cover your left ear for me. I want you to repeat what I say.
Okay.
All right, cover your other ear. Repeat what I say. So he passes the whisper test. Hearing is intact bilaterally. Okay. Once I get done with that, I'm gonna go in. I described the tympanic membrane. I did the hearing, so now I'm gonna look at the mouth. So what I want you to do is open your mouth for me. Stick your tongue out straight. Okay. Put your tongue back in. All right. Now what I want you to do is open your mouth. Swallow. All right. Soft palate is intact. Mucosa is red or is pink in color. Tongue is midline. Patient is able to swallow. Soft palate and uvula rise. Cranial nerves 2, 4, and is it 2, 3, and 6 are intact? Yeah, 2, 3, and 6 are intact. Okay. So once I do that, I'm going to go ahead and have the patient. I'm going to go ahead and do the lymph nodes. So I'm going to do the lymph nodes on bilaterally. So the first, I'm going to start up here, correct? And this is I'm going to do this one right because I ain't listening to y'all. Give me crap. All right. So the first one's going to be the subclavicular, right, which we have already done, which is here. And then from there, we're going to go to the intraclavicular, which is located right here, right? And then we're going to the humoral, which is located right here. And then from there, we're going to go to the axillary, which is located here, correct? And the armpit, because that's the axillary region. Yes.
Yes.
Huh?
My thing said when I looked at actually the same thing as pectoral.
But it's in the armpit because they touch right there. See where they come together? It's in the armpit itself. Does that make sense? And then from there we're going down to the subscapular, which is going to be located down here below the scapula. Does that make sense?
So it's on the front?
It's on the front, yes.
Oh, okay.
The subscapular. From there, I'm going to go down to, I'm going to go ahead and do the posterior thorax. So what I'm going to do is go behind the patient, all right? And what I'm going to do is put my hands on the patient's back. Once I get to the posterior thorax, I'm going to do the patient's API diameter. So as I walk around, I'm looking at the back to the side. So the patient's API diameter is 2 to 1, okay? I am then going to note, I'm then going to ask the patient to remove his shirt for me. You don't have to. We're just going to walk through this, okay, in front of everybody. He will have a shirt off at this point in time, and then what I'm going to say is I'm going to palpate the skin. I'm going to say skin is normal for race Patient has no has hair evenly distributed out through back or whatever. Patient has a mole on the left, whatever. If there's something there, I'm going to go ahead and notate it. Just pull your shirt up in the back for me so I can show them what I notate. So patient has no hair on back. There is some minor changes in skin color, sporadic throughout the back. Patient's skin color is normal for race. And then from that point in time, I'm going to go in and palpate it. And I'm going to go in here and say, patient is slightly damp, probably because he's in front of all his classmates getting a head-to-toe assessment. I'm then going to place my hands on his back and ask him to take a big breath in. Patient has bilateral lung expansion upon breathing, and then once I do that, I'm going to go in and do the spinous process. I'm going to start from the very bottom and feel for every one of the spine ends. Spine is straight. All right, bend forward for me. Just bend forward for me. Forward. Bend forward for me. Spine is straight, symmetrical on both sides. No signs of any scoliosis or bending in the skull or in the spine. The next thing I'm going to do is look for CVA tenderness. So I'm going to find the kidneys. I'm going to take my hand. Does any of that hurt you?
No.
All right, no pain or tenderness located around the kidneys. All right, once I get done with that, I'm going to go in and waive the breast assessment. All right, so the patient, I will inspect the breast for size and symmetry. I will utilize 3 positions to bring out dimpling, arms at side, hands up, and hips. Hands on hips and arms raised. I'm then also going to position the client on a pillow and inspect the quadrants of the talus spence. And then I'm going to teach the patient BSE or breast self-exam, when to do it, where to do it, and how to do it. I want them to do it monthly after their menstrual period. And typically I want them to be lying down in the same position as I teach them when I go through it myself. All right. Once that's done, I'm going to do the anterior chest, so you can lay back for me. All right, so I'm going to have him pull his anterior chest. I'm describing it. Color's normal for race. He has nipples are symmetrical, no discharge noted, some hair dispersed throughout upper chest. Patient is, that's it. All right, so once I get done with that, I'm going to go and do the same thing. I'm going to look for, take a deep breath in and out for me. A second one. And what I'm looking for is any bulges or herniations or anything like that. Because when you get into like hernias, sometimes those will move separately, or if you have what's called a paradoxical chest, where what happens is you basically break out a square of the ribs. What you'll see is when the chest goes in, that paradoxical part will go out. That's why it's called paradoxial. And when the chest goes out, that'll typically go in. So I'm noticing for anything that's abnormal, everything should be moving together. Does that kind of make sense? Everything moves in one unit, no signs of any bulges or anything like that. All right. Once I get that, I'm going to ask the patient, I'm going to ask you to take several breaths. They don't have to be deep breaths, but just take those breaths for me, okay? I'm going to turn my stethoscope back around. All right, I'm going to start here. Breath in, breath out. 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 Patient's breath sounds are clear bilaterally, no signs of wheezes or anything like that. Patient is breathing fine at this point in time. All right, so what I'm going to do now is look at the pericardium. I'm going to look for pulsation, lifts, or heaves. So what I'm looking for is the heartbeat. Do I see anything different moving there that needs to be, okay? There's nothing moving in there different. It's moving like it's supposed to. So now I'm going to go ahead and listen to the heart at this point in time, okay? So what I'm going to do is put my stethoscope on your heart, listen to it. Again, he'd have his shirt off, but since we're in front of everybody, we're not going to do that. So the first place we're going to go is where? Aortic, right? So we're at the aortic valve.
Other side. Wait.
Hmm?
What side are we on?
What?
It'd be your right side, yeah.
So you start over here,
Yeah.
Yeah.
and then you go over there. Okay.
Say your pulmonic.
What?
Continue.
His right is your left.
I can't.
Continue.
Am I on the wrong side?
I don't know where you were. I couldn't see.
I'm right here.
This side?
I'm on this side of the heart.
The right side. He's on the right.
Okay.
I'm on the right side. Okay, I'm like, wait a minute. I know I'm on the right side. So I'm going to go right here. Aortic. Pulmonic. Erb's point, tricuspid. I hear that one really good. And then the apical. Or mitral, sorry. Wait a minute. Yeah, mitral. And then apical. And while I'm there, I'm going to count a pulse for 30 seconds. Okay? Am I doing this wrong? Because you're over there making faces.
I don't know. Now I'm
No, you
confusing
didn't do it.
myself.
I didn't think so. 1, right?
I thought it was like, you know,
Where's
how you said,
mine?
like two
Anymore.
ribs under, then this is aortic.
Yes, but it's
Line,
2 ribs. So
third.
that's, so
Like
1,
this.
2 is right here is your first one, right? That's your second, or that's your second intercostal space, and then it goes across to the second because it's a Z formation. Then it goes down, then it comes back, then it goes over here, and it comes back over here. Huh? Okay. I was like, I've done this several times, guys. This is one I know. Y'all got me all jacked up. All right, so now I'm going to look at the, ask the patient to bend his knee slightly, which the bed has already got that done, right? He's on his back. So now what I'm going to do is I'm going to look at his skin, all right? I'm going to describe the skin on his stomach. You know, patient has normal skin color for age. There is some dispersed hair. Patient has a mole in the left upper quadrant, whatever's going on as far as that goes. Once that's done, I'm going to go ahead and look at the contour. Patient's stomach is flat, okay? I don't see any pulsations or movements, all right? So now I'm gonna auscultate, all right? So I'm gonna listen for 30 seconds in each of the 4. So the first thing I'm gonna do is identify the belly button, which is located here, right? So I'm gonna start here. Vowel sounds are, what?
I'm giving him.
Oh, vowel sounds are hypoactive in all 4 quadrants. And then at that point in time, I'm going to go to the aorta and listen for bruit. All right, so that's right above the belly button in the center. I hear no bruit in the aorta, the renal arteries, or the femoral arteries. Okay?
I have a
Excuse me.
question.
Yeah.
So you know how it says like some people can have like a normal pulsation of the aorta all the way down? Like I can see mine to my belly button. But how do
Yes.
you know like when it's like actually a problem?
When you hear a bruit.
So like even if you see it,
That's
as
a
long as it
normal
doesn't
thing.
have
Because
bruit.
you're going to see yours, you're never going to see mine.
Okay.
Remember, we're all built completely different.
Yeah.
All right. So I'm sure you're not the only person in this class whose aorta
Yeah.
we're going to see, is because if you're a skinny person, typically you can see that. If you're an adjacent person, you're not going to see that. Does that
Okay.
make sense?
Mhm.
Mine's buried under a few inches of subcutaneous fat. So you're not going to see that, okay? So now I'm going to palpate the abdomen. I'm going to start in the right upper, okay? Any pain? I'm going to move across. Any pain? All right, patient complains of no pain on light palp of the abdominal, of tenderness in all 4 quadrants. Now I'm going to do a little bit of heavier. So this is where I'm going to dig my fingers in a little bit. Any pain in that area? How about over here? How about here? Over here. All right, so no pain on deep palp. Now I'm going to look for rebound tenderness. He didn't have any because if he did, he would have done it during that time. So there's no rebound tenderness. Because what does rebound tenderness mean? If I go in there like this and he goes, oh, that's rebound tenderness. Does that make sense? So there's no rebound tenderness present at this time. And then I'm going to, I can feel for the liver on him. I may be able to feel it. So I'm going to come up under the rib bones. Here, I do feel the border of the liver. It's intact and feels like it's within normal limits. And I'm going to come over here and try to feel the aorta and the center line, which I do. It's intact. I do feel some pulsation within it. And then I'm going to go in and I can, at this point in time, I check the femoral pulse for amplitude. I'm not going to do that because I have to be, the femoral pulse, guys, is up in there. You have to be right up beside the instrument of destruction or whatever you want to call it when you check a good femoral artery. Now, typically, when your doctors walk in and you're doing a CPR on a patient, that's the first thing they're going to do is go in and stick their finger on that femoral artery because that's how they know if you're doing good CPR or not. All right, but never put your finger on a patient's femoral artery without gloves on, especially in a code situation, because usually the last thing they do before they die is defecate, and you don't want that on you. Trust me, been there, done that, got the t-shirt. All right, once that's done, I'm gonna look at the belly. Take a deep breath in for me. Take a deep breath out. And what I'm looking for is any herniation. So I'm looking for anywhere where the intestines have come out of the belly at that point in time. All right. And I'm gonna go in and do the male genitalia. I'm gonna verbalize this only. I'm gonna inspect the penis and scrotum for hair distributions and skin characteristics. I'm gonna palpate the penis, noting tenderness and masses. I'm gonna inspect the urethral meatus for location and discharge. I'm going to palpate the testes, the epididymis, vas deferens for size, tenderness, and masses. And then I'm going to teach the patient how to do testicle self-examination. I'm going to explain to them that do it once a month, typically in the shower or in front of a mirror. And then I'm going to show them how, on a model, how to do that. I'm not going to show them on myself or anything like that, okay? So now I'm through with that part of it, okay? So the first part is over. All right, so let's move on to the next portion, right? Which is going to be what? All right, again, musculoskeletal. So I'm going to look at the shoulders. Shoulders are midline, square to each other. I'm then going to go through and look at the iliac crest and make sure they're aligned. The iliac crest is what? The hips, right? Are they aligned with the shoulder? Would have the patient stand up while I'm doing this. The shoulder and the iliac crest are aligned, because if they're not, we have lordosis or kyphosis. Does that make sense? Because most people understand it should have their shoulders aligned with their iliac crest. Does everybody get that? All right, so now I'm going to go ahead and look at the cervical, thoracic, and lumbar curves of the spine. So I'm going to have you stand up for me. All right, stand straight up for me. Stand straight towards me. All right, I'm looking at the shoulders, the iliac crest. They are aligned. I'm going to have you turn around for me. I'm going to look at the spine, and I'm also going to look at the thoracic curvature. So I want to see an S curve in and then back out, okay? Thoracic curvature is correct and equal. All right, so now I'm going to have you turn around away from me, bend over and touch your toes. I'm going to look for scoliosis. No scoliosis present at this time. All right, so now I'm going to have you walk to that door and turn around and come back. Patient's posture and gait are intact. Now I want you to turn around when you get to me, and then I want you to walk heel to toe 5 steps that direction. All right, you can come back now. All right, so now what I want you to do is I want you to close your eyes for me. I want you to Romberg, hold on, I just had a brain fart. Huh? What's it, is it? That's it, yeah. Close your eyes and stand on 1 foot for me. Pick your left leg up, close your eyes. I don't care which leg. Hold it up for 5 seconds.
I can't do it either, I don't think.
All right, put that foot down, pick that up, do the same thing. Patient is slightly unsteady during Romberg test. All right, and that's normal. Listen, I can't do it, guys. Like, my top's too heavy for my bottom to be on one limb. I am not a flamingo, okay? So once we do the Romberg test, we're gonna go ahead and have him do, we've already had him do the heel to toe walking. So now and we had him stand on 1 foot, all right? So now we're gonna go ahead and I'm gonna feel around your mouth real quick. So what I want you to do is I want you to clench your jaw for me. Okay, very good. Any pain or anything while you do that? Okay, I want you to open your jaw against my hands, okay? I want you to try to close your jaw against my hands. All right, now I want you to push your head towards the left. No, turn your head towards the left. All right, turn your head towards the right. All right, cranial nerves, I don't remember which number they are right off the top of my head, but I will do that at the end of it because I did the test, okay? Because all I got to do is go back and do it at that point in time. All right, so now what I'm going to do is, we already did that with your range of motion on your hips. So now I'm going to go through and do fine motor skills. So what I want you to do is take your finger, all right, and I want you to touch my thumb where it ends up, okay? Now I want you to take your thumb and I want you to go 1, 2, 3, 4, 4, 3, 2, 1. 1, 2, 3, 4, 4, 3, 2, 1. Do it on the other hand for me as well. All right, that's the finger to thumb test. And then I also will have you do the finger to nose test. Close your eyes and put your head back. Touch your nose with your left finger. Touch your nose with your left finger. Touch your nose with your right finger. All right, good job. And now at this point in time, I'm going to do the DTR. So what I want you to do is have a seat on the bed for me. Now when I'm doing the DTRs of the brachio, I'm going to take the arm like this, just rest it on my hands. All right, just let it rest, rest it, just let it rest, let it rest. And then what I'm going to do is take my hammer and knuckle. I'm going to hit the ligament right where it attaches the bone. Does that make sense? And I'm looking for a jump in that, okay? Feel how his hand is jumping a little bit. I can feel it under me where he's picking it up a little bit. I'm going to do this on this side as well, nice and loose. DTR present in brachiocolitis. Then I'm going to go to the bicep, do the same thing, give you the arm here, okay? And what I'm looking for here, actually the bicep, I'm going to have you put your arm up like this and just rest it on me. Rest your arm on me. And what I'm going to do is come up here and do the same thing. Does that make sense? So I'm trying to make the bicep muscle jump at that point in time. So I'm going to go over here and give it a little bit of a... Feel it jump in my hands. You see it jumping a little bit. Now I'm going to do the same thing on the other side. Just rest it in my hands, lean it against me. Actually, I need to be over here more. There it is. All right, gonna have it in the biceps, then I'll go into the triceps. The triceps are gonna be the same thing, except I'm gonna take it, roll it over for me. Just lay your arm loose on my arm, okay? And then what I'm gonna do is come in here, right where it connects right here, okay? There it is. Feel how it jumps in the muscle down here. Same thing up here, loose, loose. And it jumps in my arm there. Now I'm going to do the patellar, which is on the back of the legs. I take a hammer and knock the patellar nerve and make the foot jump up. And then I will do the Achilles. And then the patellar is I'm going to go, the knee is the patellar. I'm going to take my hammer, do the same thing, set up on the bed with your legs dragging, hanging off. All right. Legs nice and loose, nice and loose. I'm going to come in here, about right here. And see the jump in the legs there? That's what I'm looking for in that. And then I'm going to do the Achilles where I take a hammer, go to the back of the foot and do the same thing. I'm not going to pull the shoes off to do that right now. You can verbalize that, that's fine. All right, so now I'm going to do the upper extremities. The first thing I'm going to do is look at the skin assessment. I'm going to look at turgor and temperature. Patient's skin is normal for color. Temperature is slightly cool and it's slightly moist. Patient is... Then I'm going to go in and do my pulses. I'm going to start with the brachial pulses. Brachial pulses are 2+ bilaterally. Normal rhythm and rate. Radial pulses are 2+ bilaterally. Normal rhythm and rate. Okay? And then once I get done with that, I'm going to go in and do the capillary refill. Hold your hands up like this for me. Capillary refill is less than 2 seconds bilaterally. No skin tinning present. Now I'm going to go in and do the muscle tone. So what I'm going to do is have the patient hold his hands out like this. All right. So what I want to do is feel around any pain, any problems like that. All right. Any pain. Any pain or tenderness while I do that?
No.
All right, once I do that, I'm going to go in and then I'm going to have him hold his hands out like this. Put your fingers together, spread them out, put them in, spread them out, put them in. Okay, now I want you to take them down, make a fist, let it go. Make a fist, let it go. Okay, at that point in time, I want you to take let me finish what I'm doing here. So now what I want you to do is hold your arm straight out for me. Now I want you to push up against me. Push, push, push. All right, I want you to push down against me. Push, push, push. I want you to push your arms out, like spread them apart. There you go. Now push them in. Very good. All right. Strength is good. Patient has bilateral, and it's equal bilaterally. All right. So now I'm going to look at the muscle tone. Muscle tone is present. Patient has good muscle tone in both upper extremities. And then now I'm going to take you to grab my 2 fingers. And what I want you to do is squeeze them as hard as possible for me. Squeeze, 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 squeeze. Good job. Grips are normal bilaterally. Take your hand and hold it up like this. Now what I want you to do is open your fingers. Good job. Now let me see the other hand. Good job. Patient's able to open fingers against resistance. All right. And then we already did the strength test of the upper extremities because we did all those at that point in time. Everybody on board with me? All right. The next thing we're going to do is sensation. All right. So what I want you to do is close your eyes. All right, so what I want you to do is tell me where I am touching you, okay?
Right wrist.
Okay?
Left tricep. Right tricep. Left forearm. Left hand. Right forearm.
All right, patient has sensation in all upper extremities, all right? Once I do that, I'm gonna go ahead and, I don't need to do that, so I'm gonna go ahead and do the vibratory sensation. So what I want you to do is hold your hand up for me, give me this arm. If you feel any pain while I'm doing this, please let me know. No pain?
You're doing every joint.
Yep. No, any pain there? No pain in the upper extremities on vibratory sensation. All right. Once I get that, with that, I'm gonna go ahead and we did that. So we're gonna move on to the lower extremities. You can lay back on the bed for me and put your legs up. Again, I'm gonna look at the legs. I'm gonna see the color. I'm gonna note any hair distribution and that kind of stuff. I'm also gonna just look at color. I'm then gonna go to the feet and I'm gonna test for tenting of the skin. I'm gonna pull up on the skin on both feet. If it's less than 2 seconds, I'm also gonna do a capillary refill on those at that point in time, okay? Once I've done all that, I'm gonna go ahead and have the patient feel the pulses. I'm gonna start at the plantar, and then I'm gonna go down into the dorsalis pedis, and then I'm gonna go from there to what? Or not the plantar. I'm sorry. I'm feeling for the popliteal. The popliteal behind the knees. Once I get done with the popliteal, I'm gonna go down to the post-tibial, which is right behind the ankle, and the last one I'm gonna go for is the plantar, which is on top of the foot at that point in time. I'm gonna grade those pulses and state what strength they are and that kind of stuff. Okay. And then when I get done with that, we've done the cap refill. I'm gonna look. There's no varicose veins present, and then I'm gonna go ahead and palpate for any. So there's no edema over any bony promises at this time, okay? Now I'm gonna go ahead and do the feet, ankle, knee, and hip joints for warmth, tearness, and crepitus. So I'm gonna go ahead and pick this up, move it around. I'm feeling for warmth. Bend this knee for me a little bit. Down. All right. Up, down. All right, and then also move your hips up, down, side to side. All right, and what I'm feeling for crepitus is anything that it feels like a catch in there. Does that make sense? Hip movement, knee movement, and all joints are free moving. Once I do that, I'm gonna start doing the range of motion. So the first thing I want you to do is take this foot, and I want you to take it and I would have them fan out their toes and put their toes back together. I want you to take your feet and push against my hands, okay? And then I'm gonna take my feet, pull against my hands, push out, push in, all right? Lift your legs up for me, all right? Put your legs up for me, lift your legs up for me, try to push me down, 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 good job. Now I'm gonna do the same thing. What I want you to do is bend your knee up. There you go, against resistance. Bend your knee up, very good. Now what I want you to do is put your knees down. All right, very good. So I've checked all those against resistance, all right? And now what I wanna do is evaluate the muscle tone. Again, muscle tone is present in all lower extremities. And then the grade is +2. Patient's extremities are good. So now I'm gonna do have the client close his eyes, all right? So what I'm gonna do is, again, do a soft touch. Does he feel it? I don't have his pants off right now, so I'm not able to do that, all right? So again, I'm gonna have the vibratory sensation on this one. I'm gonna do the same thing, except I'm gonna start at the knees, place it on the knee, I'm gonna place on the malleus, and then on the joints of the toes on both legs. Does that make sense? Once I get done with that, I'm gonna go through and be done with that. So what I'm gonna say is cranial nerve 1 was intact, olfactory. It was shown by the patient closing his eyes and smelling with both nostrils. Cranial nerve 2 is also intact. He has near vision, and he has visual field confirmation. Cranial nerves 3, 4, and 6 were intact. The oculomotor, the trochlear, and the abducens. The patient was able to have light reaction. If you don't mind real quick, look at my finger. Here, look straight ahead of my finger. No, straight ahead of my finger. Ready? Move your eyes and not your head. Patient's able to move through all 6 cardinal gazes. Patient has no nystagmus at this time. All right. Cranial nerve number 5 is attacked, trigeminal. The mastoid muscles with the teeth clenched. I also tested the forehead and jaw for light touch and then pain. Cranial nerve 7 is intact. I observed for exaggerated. Do me a favor real quick. Look at me. Stick your tongue straight out and make your eyes as big as possible. Stick your tongue out too. All right. Now pull your tongue in. All right. You're good. Patient's able to make extreme facial expressions. Cranial nerve 8 is the auditory nerve is intact. Not yet, because now I have to do the. There it is. All right. So what I need you to do is tell me if you have any pain or you feel this or hear it.
Don't feel it.
Okay. Do you feel the vibration in it? Okay. How about here? Do you hear this noise? Okay. What about this noise? All right. The patient passed both the Weber and Rene test. That proves cranial nerve number 8, the auditory nerve, is present and working. The next thing we're going to do is we saw the movement of the uvula and the hard palate upwards while the patient said "ah," and now I'm going to test the patient's gag reflex. So patient gagged, so cranial nerve 9 and 10 are present. All right. So cranial nerve level 11, the patient was able to move his shoulders against resistance, and he was able to move his head side to side against resistance. So cranial nerve 11 is intact. All right. Patient has cranial nerve 12 intact because he's able to swallow and his tongue is midline. All right. That's it.
Yay.
Does that work for you?